And thank you everyone for joining this webinar. As Kate's mentioned, this is one of the webinars that's been organised by the Economics of Children's Health and Wellbeing Special Interest Group. And we're delighted to have Anna Kwaka-Rumi from the University of Ghana with us. And she's a research fellow based at the Institute of Statistical, Social and Economics Research at the University of Ghana. She's published widely over the past two decades, broadly in the area of developmental issues in health economics, health services delivery, social protection, and gender-based analysis. And we're delighted that she's going to be able to speak to us today on the economics of adolescent, sexual, and reproductive health interventions in Ghana and Senegal. So the format we're going to take is the usual format. Anna's going to present for a maximum of 40 minutes, and that should allow us some time at the end for the questions and comments. So thank you very much. Anna, over to you.
Thank you very much, Travis. Thanks for the nice introduction. And I'd like to say that this project started in 2019. But we had a brief break because of COVID. We struggled to continue till 2021 when we all got back to continue with this project. So I'm here to present the findings from 2 countries, Ghana and Senegal. This will be the outline for the presentation, and I will try and go through all of this within the next 30 to 35 minutes. All right, so to give a background to why this was very necessary, we realized that across the ECOWAS region, where Ghana and Senegal are countries, pregnancy and delivery complications among adolescent and young girls contribute significantly to mortality in the region. We also realized that there's a strong desire to address sexual reproductive health challenges and the needs of adolescents, especially girls in the region. But there are very few studies that even consider the cost of the interventions that have existed in the past or currently. But then knowing these costs has a very great potential to improve the services that we offer, and also, among other things, to enable us to engage with the key stakeholders and make sure that these services are reaching their beneficiaries. The funding aspects we realized is missing in the literature completely. And so to start with, we looked at expenditure of our governments on reproductive health in general. And you realize that many of the governments, some had no data at all, Gambia and Guinea-Bissau. For the countries that we do have data, you realize that a lot of them just contribute about 3 to 6% on reproductive health in the region. So for the project, the 3 aims were to look at what we term in the project as priority interventions, and also to find a way of bringing all the stakeholders together to identify these priority interventions, to identify the components of these priority interventions, agree on them, and then cost the interventions. And also, once that was done, to look at what the resource needs were, what the funding gaps were, and also to identify financing strategies to implement these interventions, more as a multi-component and multi-sectoral approach. I'll show you how we did that. So as part of the design of the project, we needed to map out our stakeholders, and this was very, very important right from the onset. So we did this in our initial workshops where we brought all the key stakeholders on board. For Ghana, we had the Population Council, we had civil society organizations, we had the health sector, the Ministry of Gender and Children, and all the other development partners who work within the region. So we did this mapping. We had face-to-face engagements with all these stakeholders before COVID. After COVID, we had to move to virtual meetings and also engaging with the technical working groups. So for Ghana, And for both Ghana and Senegal, we used the West African Health Organization criteria to identify what we termed as priority interventions. And ultimately, these priority interventions must target interventions that look at adolescent health. It must be nationwide. It must look at social determinants. It also must target knowledge, behavior, and lifestyle change. And so we did this, and we had this situational analysis done using this criteria to identify all the interventions that were available. For Ghana, we identified using this criteria 7 interventions, but when we had the key stakeholder meetings, 4 of these interventions were prioritized for costing. And I just want to show you some of these interventions that we identified. So I'll just quickly go through them. We have an intervention called adolescent clubs. These clubs were meant to engage students in schools and in the community. Then we had the safety net program that looked at providing social support for pregnant adolescents, especially those who were very young. And then we also had the Ghana Adolescent Reproductive Health Program that also targeted reducing teenage pregnancy. Then we had the nutrition program that looked at supplementing the meals of adolescent girls by giving them weekly iron and folic tablets free of charge, and basically to help prevent anemia. And so that was supported by the UNICEF through the Ghana Health Service and Ghana Education Service. Then we also had a program that supported national capacity to enhance family planning and comprehensive maternal health services. And then we had a program that looked at empowering adolescent girls through comprehensive sexuality education. We prioritized these 4 after the meeting. And so these prioritized interventions were the interventions that were costed for the project. For Senegal, they identified 12 interventions and they prioritized 5 for costing. I will briefly go through some of these interventions that they had. So they have a project called Girls Education Project that looked at peer education and mentorship, looking at youth empowerment, all forms of violence against girls and children. That was the focus of that project. They also had a project that looked at groups for the study and teaching of population. Also to schools, again, we see how, the Ministry of Education becomes very focal in many of these programs across Ghana and also in Senegal. Then there was a Marie Stopes International Senegal Youth Spaces project that also looked at the provision of health services to the population, both rural, urban, and youth, and also to the poor. And then they had a youth promotion project. They also had a project called EcASaRH de Saint-Louis that also looked at improving access to ASRH services. Then they also had a project called Association of Senegalese for, I think, Good Family. That's in French. It also focused on adolescent girls' health, looking at education and also well-being. So overall, most of the programs that we identified within the countries were in line with the country's response to the needs of the adolescents. However, the downside was that many of the programs and the interventions were over-concentrated in one area. So for many of the programs, you look at the criteria and the components, and it will focus on access to information, for example. But overall, we realized that sustainable funding remains a key challenge. The review that we did prior to the selection of the priority areas shows that indeed most of these interventions will begin as a pilot, and they were never scaled across the country for lack of resources. you will see how this plays out when we look at the cost figures for Senegal. So we also see a trend where the continuity of the interventions often remains in a balance with insufficient funding, especially from government resources, being a big challenge overall. So let me quickly go through the cost interventions, and I will go through how we did this for both countries. So the costing analysis follows what we would typically do for programmatic costing. So we will base this on activity-based costing approach, where we look at what goes into the programs and analyze how much it costs per these cost centers that we identified. However, I must point out that the analysis did not include the cost to the adolescents or their families or their caretakers in assessing the interventions. So we omit the broader societal cost of the intervention. And this is because that was not the focus of this particular project. We know that there's a very good, reason why we should also know how much it costs adolescents and their families. But for the scope of this project, we just looked at the programmatic cost. All the activities that are associated with this, with these interventions were identified. Where we could, we costed them individually. And then we had an Excel-based tool that was developed by the team and also validated by key stakeholders that was used to aggregate the findings. So the data on inputs and assumptions were agreed by the study team. Our key informant interviews within our respective stakeholders were conducted for additional information. And this process for Ghana started from September 2021 and it ended in June 2022. I will highlight some of the challenges we had, but most of the challenges we had was with disaggregation of data, because for many of us, programs the interventions are implemented as part of a broader reproductive health package that includes programs that are targeted not just at adolescents, but also mitigate the cost. But we did some assumptions, we made some assumptions, and we analyzed the estimates that were given to us. For Ghana, we did the analysis over a 7-year frame, starting from 2015 to 2021. So for the cost components, I will not be able to go through all of them, but we had these costing components. So we've run through the type of service, the target group, the duration, the funding sources, total received, total expenditure. We had with the help of our key stakeholders, we're able to come up with some of these cost centers, conference, outreach. This is very straightforward programmatic costing that was done for this project. So we go down to actually explain what goes into each of the components. And this is done in detail, but for the sake of time and the fact that we need to be able to share more of our data, I will not go into each of these explanations. But this shows the assumptions and the different categories that we have for the costing that was done. And one of the things I need to point out is that for the salary cost related components, we did not include government expenditure in terms of how much the government was paying for its workers who worked in the facilities, for example, the public health facilities. So that component is not part of this costing. This costing is, this salary cost is related to the programs. So for example, any administrative officer who was part of the program, who was paid on the program, would have that cost component included. But salaries that are paid by the government to the workers were not considered, because we tried to get that information, but it was very difficult to disaggregate. So we have these other cost components that you can see here. So I'll share briefly the main results from Ghana, and then I'll go on and share the results from Senegal. So for the total cost for 7 years, again, because of data gaps, we see a variation of how much was spent per year. So we have as low as $254,000 for 2017. And that does not mean that in that year we did not spend money on adolescent reproductive health programs. It was very difficult to find data for that year, and also for the previous year, 2016. But ultimately, you see a range of trend where we're spending about $8 million a year to about $12 million, and the highest we recorded in 2020 on adolescent reproductive health interventions. So we see that the decline in funding in 2021 may be as a result of the impact of the COVID-19 pandemic. Generally, during the COVID-19 pandemic, there was what we call resource reallocation, not just in Ghana, but across the world. So definitely, we see some of the funding, that potential funding that could have gone into ASRH funding going into other areas. So again, as I pointed out, 2017 was because we lacked data for that particular year. We looked at where the cost was concentrated, and for Ghana, we see that a lot of the money, at least more than 60%, would go into an area where we called strengthening national capacity in delivering high quality integrated family planning and comprehensive maternal health services. And this actually showed what I talked about previously about disaggregation of data. Most of the programs are done in an integrated manner, which makes it very difficult to break up what goes specifically to adolescent reproductive health. We also looked at some of the major cost centers, and we also see that the results are very mixed, but salary-related cost seems to be very high. For example, in 2015. In 2016, we see travel costs also becoming a very significant cost center. We also see that commodities and supplies follow sort of a general trend between 2015 and 2021. We see that at least we are spending about 1.8 million to 2 million over that period from 2018 on commodities and supplies, and this will cover condoms, all the other family planning interventions that are geared towards the youth. So just to conclude on what we found in Ghana briefly, we can see that, yes, there's some form of erratic fluctuations in the funding of interventions over the years. And that is because of some of the data gaps. But we also reflect on the fact that it could also be the fact that ASRH funding in Ghana is very susceptible to external aid and internal shocks. And so given the limited internal financial support to some of the core ASRH activities, and the fact that our donor-funded activities take the lead, we see how these trends become very visible. We will go on and share some of the findings from our qualitative study. So I would move on to the results in Senegal. So in Senegal, again, we had severe challenges with data. So at the end of the day, we had data for 1 year, 2021, and therefore we considered this as a case study. And then the data analysis was done on cost per recipient. So for data for the 4 interventions that were identified, depending on the type of intervention and location, we had cost per recipient during implementation ranging from about 0.8 to $2 per recipient. And then for those who were in targeted programs, we had the cost ranging from 0.9 to about $38. Majority of the cost, again, just like we saw in Ghana, was for capacity strengthening of adolescents and communication and sensitization to communities. School-based interventions seems to be less expensive using the cost per recipient approach. So these are the disaggregated results. And I must point out here, looking at, I'm not sure if my cursor will move, but yes. So looking at the implemented budget, for example, for the first program, promoting life education clubs, you realize that the main figures are in French CFA, no, in CFA, in West African CFA. And then the figures are in red are in dollars. This is about 600 per CFA, I think, yes, for the 2021 results. And so it comes down to about $122,000 for this program. But then if it needed to be scaled up, we would be looking at about $1.1 million to scale it up nationally. The same for the third project that looked at adolescent and youth spaces in promoting health. The budgeted program was about $19,000, but if it had to be scaled up, we are looking at $9.4 million. So it shows you the gap between what a national scale up will look like and what is currently being implemented, many of them as pilot programs or initial programs to see if it's possible to scale them up. And I must also point out that sometimes for funding reasons, many of these programs don't go beyond the pilot phase. So for some of the recommendations that came from the costing analysis, this is not exhaustive, but just for the sake of time, we just want to point out a few of them. The need to look at inclusive multi-sector partnerships so that we cut down costs and also make our programmatic interventions more effective. And the fact that we also needed to encourage a more participatory approach to get in buy-in and also commitment. On the research side, I have talked about this quite a lot. The fact that we need to look at how to disaggregate activity accounts for the interventions so that we can find a way of capturing the components that accrue to our adolescent reproductive interventions in a more objective manner than we have done in the past. And also to push the analysis beyond just the costing, but to look at cost effectiveness and efficiency studies to determine how these interventions are performing and whether we're really getting value for money. So to go beyond just the costing, we went back to our stakeholders in a way to find out what the funding gaps were in Ghana. And we did the same in Senegal. Because of lack of data, we needed to talk to them face to face. So we had a qualitative aspect of this study where we looked at what the resource needs were, what the funding gaps were, and what the strategies for financing ASRH programs could be. So I present in this section the results for Ghana. So generally, we recognize and accept that most of the funding is from international organizations or international NGOs and CSOs. And worldwide, we know that at least from what we got from the literature, there has been about a 25% reduction in life-saving health interventions for women, children, and adolescents post-COVID. And we continue to see how these reductions in aid support widen the funding gap for these interventions. In Ghana, again, we lack published scientific evidence about the magnitude of the funding gap, but through our key stakeholders, interventions, and studies, we were able to come up with some of an estimate of what the picture looks like now. We did this by personal interviews, phone surveys, online questionnaires, just to have an idea of what the funding gap was. We talked about 30 key informants. We talked to these from 15 stakeholder institutions from 2020 December to 31st of January. So these actors would be in a myriad of interventions looking at advocacy, counseling, education, provision of adolescent healthcare needs, supporting other ASRH interventions. And this is just to give you an idea of what the picture looks like in Ghana. So you would have the Ministry of Health, the Ghana Health Service, Ministry of Education, and what we did was to map where the funding from the funding sources from the ASRH interventions. And just looking at this table, you just recognize that a lot of the funding were coming from international agencies, UNFPA, USAID, World Bank, DENIDA, UNICEF, the French Embassy. Some relied on internally generated funds, but for most of these interventions, they were supported by funding from external sources. So we talked to key stakeholders, and at least 10 out of them said, we definitely do not have a specific national budget designated to financing ASRH interventions in Ghana. And that from the public sector, what they said was that funding really over the past years has been through donations or grants from development partners. Looking at the perspectives of ASRH funding gap in Ghana over the past 5 years, at least from what we gathered from the public sector participants, they agree that the funding gap has increased. They're looking at an annual funding gap that exceeds about 40% in 2018, and at least has reached about 60% in 2020. And this trend continues to follow. As we speak, we continue to see how there's a shift in fiscal allocation from some of these interventions, especially post-COVID. And from them, what they also reflect on is the fact that the government provides less than 30% of its commitment to some of the budgeted programs. And it's not just the reduction in the commitment, but also the delay in the release of the funds, which also has an impact on which kinds of interventions are actually implemented. For the NGOs, they have money that is allocated to them for particular projects. And so what they told us was that their partners will rarely withdraw committed funds for the interventions. Once those funds were committed, they would be released and also be released on time to enable them to continue with their projects. But over time, they can see that as these economic crises continue, energy problems in Europe and elsewhere, we could see a potential 50% reduction in donor funding. We can also already see that there's a decline between at least 30% between 2021 and 2022 for humanitarian and charity works in Africa. So that should give you an idea of what will happen and what continues to happen in the space. So definitely I've gone over this, but one of the things that I needed to highlight was the fact that the lack of data also is presenting a compelling case for investment from our partners. We see the value of data when we start doing some of these evaluations. Without the data, there's really nothing to present. So our strategies for addressing the funding gap in Ghana and Senegal, some of our partners talked about developing a long-term national financing strategy for ASRH. Again, this had two sides because the way the policy is structured in Ghana is structured in an integrated manner. And so, again, really looking at just ASRH within the national budget could be problematic. Some also talked about co-creating interventions. I've mentioned that. And then also conducting more comprehensive cost-benefit evaluations so that we can use that to advocate for more funding. In Senegal, again, we see a similar trend. According to their health accounts data from 2017 to 2021, what the findings show is that households remain the main source of healthcare funding. The state contribution remains at an average of 35%. So again, the findings show that in Senegal, a lot of the partners such as UNFPA, USAID, Plan International, UNICEF, and others continue to be the key supporters and key financiers of these interventions. So for some of the programs, they show some of the funding gaps. And you can see that, again, there are high funding gaps, huge funding gaps for many of the programs. For one of the programs, activities were halted for the lack of funding. And this is it's something that we have seen over time. So for strategies to address ASRH funding gaps, from Senegal, some of the strategies were to encourage local authorities to include ASRH in their health budgets, encourage companies to devote some of their corporate social responsibility to these interventions, strengthen partnerships, pool resources, and also integrate ASRH components into all government youth integration programs. So to conclude, I'd like to highlight the fact that in both countries, we recognize that most of the funding is from development partners with some contribution from the government. We also recognize that we need to have a multi-sectoral approach to really anchor the implementation of ASRH interventions. And from our major stakeholders, it's also clear that even though adolescent health is a priority sector, they all agree that it is. There's no specific budget line dedicated to this category, and so it makes it very difficult to estimate how much is going in and how much is needed. And so we recognize the fact that funding gaps do exist, and they continue to escalate. But we also we are not very clear on how funding will come in and how sustainable that funding will come. So these are the key concluding issues. We had funding from IDRC to do this work, and so we are grateful to all our funding support and all our key stakeholders who engaged with us from the beginning of this project. And we also want to say thank you to AHIA Special Interest Group for allowing us to present our results today. Thank you very much.
Thank you so much, Emma, for your presentation. That was tremendous. Thank you. Are you happy to stop sharing your screen, and then we'll open it up for sort of questions and comments? If I can ask all participants, if you want to ask a question or make comments, could you either just raise your hand, and we'll come to you in order, or use the chat function. So thanks once again, Emma. So open to the participants. Please feel free to sort of raise your hand if you want to ask a question or make a comment, or use the chat function. Whilst people are thinking of questions, perhaps I could start with one. When you talked at the beginning about this process for prioritizing interventions that you subsequently generated these data for, I wondered if you could say a little bit more about what criteria you used to sort of move from sort of the larger pool of interventions to that smaller pool of 5 or 6 interventions that you subsequently focused on in Ghana. You know, what sort of evidence do you draw upon to use any sort of established frameworks for sort of prioritizing interventions?
Okay, thanks. So I'll just quickly go over that. So for an intervention to be considered, it had to be nationwide. It had to target adolescents, and also had to target particular interventions that will help them. So behavior change, peer support, you know, and it had to have some form of sustainability beyond a pilot intervention. So we use these 4 criteria to select the programs that came in. It had to go beyond the pilot phase, because most of these projects would be pilot projects that will end after 3 months or 6 months.
Oh, okay. But was it sort of taken as given that there was a strong, an evidence base for their sort of effectiveness and potentially even cost effectiveness?
Yeah. So for many of these programs, none of these evaluations have ever been done. And so again, that's the limitation. If we had these, it could be very easy to pick up those estimates right from the beginning.
Yeah. Thank you. Thanks. Doris, would you like to come in and just briefly say who you are and where you're from, and then ask a question?
All right. Thank you very much for the insightful presentation. My question has to do with the issue of integration of services as against coming up with the cost associated with a particular service provided for adolescents. And I mean, vis-a-vis lack of data. So what exactly has been the challenge? Is it because there's no data on these types of interventions in relation to their costs, or it is the integration of the services that is also kind of resulting in making costing of each of these different interventions very difficult? I mean, in doing such studies like this.
Yes. So thank you so much, Joy. So you really hit at the key problems that we had from the beginning. So when we started this process for Ghana, for example, we went to the Ministry of Health, to the Ghana Health Service. And what they told us is, previously they had a policy for adolescents. So that policy for adolescents would attract specific grants for specific adolescent reproductive health interventions. And so if we had followed through, we would have interventions that were geared to adolescents, and we could actually follow the trend of cost for those interventions. But down the line, everything was integrated. So we're talking from 2016, this policy from adolescent reproductive health policy was changed to a multi-sectoral policy where we have everyone integrated, what they call RMNCH. It's a very long name, but what it shows is that all the services are integrated. So you cannot actually say, I want to look at just adolescents and how much is going to adolescent care. But for the funders, for example, UNFPA and all the others, they have specifically targeted populations that they look at. So if you go to them, they can tell you that this amount was specified for adolescents. This amount was specified for mothers. And so from them, we can do that disaggregation. But for the Ghana Health Service or the Ministry of Health, that is a challenge because they look at the whole picture, you know, the life cycle from babies all the way to mothers. So that has been the challenge for us. But we still need to know what is going towards adolescents, because what we see is that they seem to be missing because the focus is on mothers and children, and then they're just pushed to the background and given a small corner in the hospitals, and you know, those dynamics are not working. But we really need to know how much it's costing us and what we need to do. Thanks.
All right, okay, thank you. Maybe going forward, Ghana may have to think of adopting the model that the other international non-governmental organizations are using, where they can easily tell specifically, though they are having different programs for different populations. Maybe, I mean, at the end of the day, that is how they're able to do their costing, because, I mean, things are actually purchased or supplies are made for all these things. I'm sure they all come with some kind of cost. So maybe the model that these international NGOs are using may also be very good for Ghana to adopt that, to help us know, I mean, do these kinds of studies, because it's really, really interesting and it's kind of insightful. Thank you very much.
Thank you, Doris. Thank you.
Thank you, Doris. Thank you. There's a question and a comment from Mel in the meeting chat. I don't know if you can see that. I can read that out. Mel says, "What's the place for deliberative processes in priority setting in Ghana in your own perspective? Discussions that go beyond just using ICEs and numbers in decision making." I know that Ghana is trying out methods such as adaptive HTA, and then she goes on to say using ICEs as a starting point for priority setting rather than the end goal. I guess I don't know if you want to come back to that point, you mentioned there's a lack of data that can, but do you want to sort of respond to that?
Yes, most definitely. I mean, I agree totally that we need to find a way of objectively looking at how we allocate resources. And we have started the process, but it hasn't galvanized into issues as we want, areas as programmatic intervention. So we are currently doing HTAs around vaccines to the NHIA and all of the other institutions. But we see the relevance of going beyond just vaccines for these decisions around how much money is to allocate to projects. But if we don't have the basic costing data, it will be very difficult to even evaluate the ICERs to be able to use these to make these decisions around which areas to prioritize. And so for me, the lack of data is a very, very big issue. If we don't make efforts or invest in finding data for what we need to make these analyses, then we are just probably wasting money. If you ask me from where I sit, we really must invest in data.
Yeah. Important generating evidence and sort of cost effectiveness evidence that can inform these priority setting exercises. Yeah. Sonia Angeline has added, asked a question: what are the challenges to use an activity-based costing, knowing that some expenditure items can be found in several activities? I don't know if you can respond to that based on your experience.
Yeah. So Sonia, you're so right. We struggled. I don't know if you were here when I was talking about salaries, for example, in Ghana. So how do you portion out the salary of a nurse who works for both mothers, I mean, for adolescents, for children? How do you find that percentage that goes to adolescents? And it was difficult, and it's still very difficult. We can use the time use analysis to sort of make estimations around how much time is spent on adolescents, and then use that to calculate how much it will cost a hospital to perform certain activities. But again, it's very, very time consuming, and we have tried to use that in other projects. We're still working on how that would look like. But to be honest with you, we had a caveat and an assumption around that to say that we did not include, for example, salaries of workers who worked on these interventions, because it was very difficult for us to find an aggregate for what they did for adolescents. I hope that sort of gives you an idea of the struggle we had.
Thank you, Emma. Any other questions or comments from participants?
I also want to find out if anyone has done this kind of study before.
It'd be interesting
in
to
other
hear from
countries.
from
Do
others
they have any
about their own
experience?
experiences. Yeah, particularly around the challenges they've come across in terms of cost. Estimating reliable cost estimates, either for adolescent sexual and reproductive health interventions or health programs more broadly. Anybody else wants to come in on that point? Well, another question from me, Emma, was around like the sustainability of these interventions, given that so much depends on sort of external funders. How do you sort of see that panning out?
To be honest, what we have done in galvanizing advocacy around this funding gap issue is to look at how we can channel some internal funds, internally generated funds, for example. But again, it's a bit of a challenge because there's so many other activities that are also vying for the same pot of money. So somebody mentioned that we should have an investment case for ASRH activities in Ghana. I think that the data shows that we need it for our children. They're developing mental health issues, very young. I don't know how much more we can do to show that we need to move funding from other areas to adolescent reproductive health issues. So until we can see that as a very important need, we may be stuck with relying on external funding. But it's not just for adolescent reproductive health. This cuts across many of our vertical programs, malaria, HIV. They're all heavily funded. And so it's a general problem we have, but even more acutely for ASRH interventions in Ghana. So,
yeah, thank you. Thanks. Any final questions or comments from other participants?
Yes, we also have our Senegalese researchers on board. I don't know if they also want to say something before we go.
Yes.
I've seen Abdoulaye Diallo.
Yeah, would you like to introduce yourself?
Yeah.
Good morning, everybody. Thank you, Amma, for your very great presentation for the results. For me, I don't have, I think, comments you already say, I think, enough about this project. At what point one thing I want to point again is the difficulty to have, data for costing, because the people, I think, some implementers, they don't have, the data. If I don't know why they don't keep the data relating to the costs, So that was our problem. That's why we cannot have the data during a long period. That's why we decided to have one point data collection, and we chose the very nearest year in order to avoid missing data. But the real problem for us is how to have a system in order to keep the data relative to cost. This is a problem for us, and then I think that in the recommendation, we say that the health account system should put, I think, a system in order to capture this data in a timely manner. Thank you.
Thank you, Abdullah. Thank you.
Thank you very much.
Thank you. Okay. Any final question or comment? Otherwise, we'll. No. Okay. Well, thank you so much once again, Sama, for your time and for your
Thank you so much.
And just remind everybody, all participants will be holding another of these child health and wellbeing SIG webinars towards the end of the year. So you'll receive details via about the exact sort of date and time of that webinar. So thank you once again, everyone. Thank you.
Thank you so much for having us. Thank you.
Thank you. Bye.
Bye.
Thank you. Bye.